Great. We are going to get started in the next session. If I could ask everyone to gradually wind down those wonderful conversations and take a seat. Great. I want to say hi to all of those who are joining us online. My name is Ananth Shenoy. I'm an outpatient internist, and I have the privilege of helping coordinate the medical student and resident abstract competitions each year. I want to just call out that we're having a poster session this afternoon. Please stay for the governor's reception. And we also have 3 blocks of 3 oral presentations scattered throughout our conference. We have some very, very brave residents who will be speaking in front of our entire group. This is our first block of 3. Each speaker will have 7 minutes to share an insightful and instructful and interesting case, and then we will have time for 2 to 3 questions. What I'd ask is for those in the audience, if you have a question, to raise your hand and then shout the question out when we call on you or we point to you. So with that, I would like to introduce Dr. Daniel Weber, who is joining us from Madigan, who will be sharing with us an interesting and instructful case in the GI field. Dr. Weber. Hello. Hello. Dan Weber, I'm a PGY who wasn't over at Madigan Medical Center in internal medicine residency. I'll be presenting a case on cholestatic liver injury in a patient with chronic portal vein thrombus. I am my own person. So the case starts out, patient's a 30-year-old male with a past medical history of chronic thromboembolic pulmonary hypertension, status post a thromboendarterectomy, and a portal vein thrombus related to protein C deficiency. Currently on the DILAC, who proceeds to the GI clinic for evaluation of elevated liver enzymes for approximately 1 month. His notable symptoms were alcoholic stools, dark urine, and generalized pruritus over a similar time period with an unremarkable physical exam. His lab elevation was significant for an alk-phos in the 900s, and the AST/ALT of 200 and 360, respectively, with an R factor that fluctuated between a mixed hepatocellular and cholestatic injury to cholestatic pattern. His liver synthetic function remained intact, as noted by normal albumin and INR, though stable chronic thrombocytopenia to the 70s. On subsequent laboratory evaluations, IgG4 level and anti-mitochondrial antibodies were within normal limits. Over the course of 6 months, multiple advanced imaging studies were obtained. In summary, an MRI with and without contrast, right upper quadrant ultrasound, and a CT album pelvis with contrast showed evidence of portal hypertension suggested by splenomegaly and portal systemic varices. Cavernous transformation of the portal vein suggested by multiple collateral vessels along the intra and extrahepatic segments of the liver, and mild dilation of the intrahepatic biliary ducts. The biliary findings were confirmed on MRI, MRCP, showing multifocal beta appearance of both intra and extrahepatic biliary ducts. The liver elastography could not rule out mild to moderate fibrosis with a score of 7.3 kilopascals. All relevant studies non-invasively found no evidence of cirrhosis. As you can see here in the image, the arrows without stems indicate an area of stenosis, whereas the arrows with stems indicate an area of dilation, most significant in the left hepatic biliary duct. In this patient with known chronic portal vein thrombus with mixed cholestatic liver injury pattern and non-cirrhotic cholangiopathy, a large differential was considered, including IgG4 associated cholangiopathy, PSC, and other sclerosing cholangiopathies. Considering this patient's history of portal vein thrombus, portal cavernoma cholangiopathy, or PCC, was considered highest on the differential. This is a rare and often under-recognized complication of portal vein thrombus when increased portal vein pressure causes collateralization to a tortuous and dilated veins of the hepatic and biliary system. As you can see here, there's a picture of the general anatomy of the biliary system with several small venous plexuses that drain blood from the biliary system. The progression of PCC involves the periductal venous plexuses encircle the biliary ducts, become more progressively dilated, and externally compress the biliary ducts, which can cause morphologic changes as represented by the multifocal appearance of the biliary tree on MRCP. As this process continues, local areas of ischemia and inflammation are created, leading to sclerosis and scarring, which can later impact the capillaries and arterioles. Once this occurs, the damage becomes irreversible and can progress to cirrhosis and end-stage liver disease, especially if left untreated. Largely depends on symptom burden. Asymptomatic patients are typically monitored closely, and labs are in imaging adding beta blocker for portal hypertension, and ursodiol. However, ursodiol has limited data in terms of therapeutic efficacy. Symptomatic patients, such as this case, may benefit from biliary decompression via ARCP. In patients with recurrent biliary obstruction and severe portal hypertension would benefit from portal decompressive procedures such as surgical portosystemic shunts. Long-term prognosis depends on the control of the portal hypertension and recurrence of biliary obstruction. Patients remain stable usually once decompression is achieved. If this process progresses without treatment, it again becomes irreversible. Taking it back to the case, the patient due to diagnostic uncertainty at the time, the biopsy was offered to allow other cholangiopathies, but ultimately elected not to pursue due to the likelihood of sampling error or missing true diagnosis of PSC. Additionally, a transvenous intrahepatic porosum shunt was offered, but again, the patient elected not to pursue given the invasive nature. The patient was, however, amenable to conservative management options, including beta blocker to reduce risk of portal hypertension complications and a colonoscopy to rule out inflammatory bowel disease, which was negative. In summary, PCC is a rare and likely under-recognized complication of chronic portal vein thrombus that is difficult to diagnose and with limited data to aid in management. The overall imaging and clinical features with PSC or other cholangiopathies underscores the importance of integrating high clinical suspicion, clinical features, laboratory, and radiologic data. Early recognition and intervention, including potential portal vein decompression, are critical to prevent the progression to cirrhosis and the need for liver transplantation. These are my references. Any questions?
What was behind his initial thrombosis? Was that worked out at that time? Did that play any role at all? Issue.
So the patient at the time of the diagnosis, he was found to have protein C deficiency, and at some point had a IBC filter placed, and was later transitioned to a DOAC. He remained on the DOAC at the time of this presentation, and imaging was difficult to rule out any kind of portal vein thrombus or a manifestation of his portal cavernoma cholangiopathy.
Did he remain stable on the DOAC, or did he progress?
He had persistently elevated liver enzymes since the diagnosis of the portal vein thrombus. This presentation to the GI was initially brought on by an acute elevation over the course of the month, on top of his presenting symptoms, which were the pruritus, the acolic stools.